Hello, good afternoon, everyone. Thank you all for coming. I really appreciate this opportunity to talk to you all about stroke today. And before I begin, I was going to actually focus today on ischemic stroke, which is the type of stroke which results from a clot that develops and causes symptoms. But before I begin, I wanted to just begin by asking you all, when someone talks about stroke, what does stroke mean to you all? If I could have some volunteers, what does stroke mean to you?
Death. I never died. She was gone before she did.
Okay. Death. Yes. Paralysis, yes. Okay.
Sitting your left wrist.
Yes. Going to the doctor right away. Very good. Very good. Any other answers? No?
If you think you're having one, can you take an aspirin?
Not necessarily. So you want to actually hold off on that because it all depends on the type of stroke that you're having. For a type of stroke called a hemorrhagic stroke, an aspirin actually can be fatal. Yes. Yes? I'm sorry? Yes, it may affect swallowing. Very good. Yes? Sure, disability, yes, absolutely. Very good. So I will begin with just going over just some key definitions first. Basically, stroke, what it is, it's a sudden disruption of blood flow to the brain cells. And that can occur through two different mechanisms. The first one is it could be because of a blockage of blood flow to the brain. And that can happen through various different ways. It could be because of a clot forming in a specific blood vessel in the brain. It's in a blood vessel in the brain itself. It could also be a clot that travels from somewhere and ends up in a blood vessel in the brain. And it could also result from sometimes a phenomenon called hyperperfusion, when the blood is not reaching the brain as it should. And then another way that a stroke can occur is if there's actually a rupture of a blood vessel in the brain, and that's the other type, which is the hemorrhagic stroke. Stroke actually happens to be the most common life-threatening neurological disease. It accounts for 1 of every 15 deaths. It's actually the 5th leading cause of mortality and death in the US. And this is actually an improvement. It used to be the 4th leading cause of mortality or death in the US, but that has gone down because of better control of risk factors, which can increase the risk of stroke. And it's also the leading cause of disability. And believe it or not, 80% of strokes are actually preventable, and there are rapid treatments available to minimize the brain damage. Stroke, it seems to increase in incidence as we age, and this is something that's observed across all ethnic groups. But what we have noticed is that there is a disparity of stroke incidence in the various ethnic groups. Certain ethnic groups, for example, African Americans are more likely at a younger age to be diagnosed with a stroke. But what we have noticed is that as we all age, regardless of the ethnic groups, that incidence, or that disparity, I should say, between the ethnic groups, that does go down. And what we are noticing is that, luckily there is a decline in mortality over time. And the reason is that a lot of individuals are working with their providers to ensure that their risk factors for stroke are being well managed. And as a result, the incidence of stroke is going down. Stroke symptoms. So stroke symptoms usually occur suddenly. So it's usually the sudden onset of weakness, and that could affect the face, arm, or leg. It's the sudden onset of numbness, which could also affect the face, arm, or leg. It could be the sudden onset of vertigo, dizziness, gait unsteadiness, or patients may have a difficulty with coordination suddenly. It could also be the sudden onset of vision changes. Either it's vision loss or double vision. It also could result in the sudden onset of confusion, slurred speech, And the hemorrhagic strokes can also result in a severe headache, and usually it's the sudden onset of a very severe headache. And sometimes it could actually also not just affect one side of the body, but it could affect all four extremities and cause quadriparesis. And that is a stroke that affects a very critical area of the brain called the brainstem. And finally, it can also affect areas usually supplied by cranial nerves. For example, you may have all heard about Bell's palsy. That usually causes facial weakness. But stroke also can cause facial weakness, but it usually causes weakness in a different area than what is usually caused by Bell's palsy. Now, the key thing to understand is that stroke symptoms occur suddenly. Whereas with other neurological disorders, the symptoms can occur more gradually, and that's usually how you can tell these stroke symptoms apart from other neurological disorders. So it's usually the sudden onset of any of these symptoms, and which symptoms a patient experiences all depends on which blood vessel in the brain is affected. Now, there are some stroke mimics that we have to be aware of as well. Sometimes there can be other systemic disorders which can result in stroke-like symptoms, and yet the patient may not be experiencing a stroke. Now, this is not something that patients may be able to figure out themselves, so they do still have to present to the hospital to have the providers try to better understand the cause of their symptoms. So sometimes if patients have a seizure, that can also result in weakness on one side or paralysis. It can also, hypoglycemia, if a patient has a history of diabetes and if their blood sugars fall low, that can also result in confusion, and it could also mimic a stroke as well. Hemiplegic migraine headaches. So some patients who experience severe migraine headaches may also have stroke-like symptoms associated with those headaches, such as numbness on one side or weakness. Hypertensive encephalopathy. If the patients have a history of high blood pressure and the blood pressure becomes very elevated, very uncontrolled, that can also sometimes result in stroke-like symptoms. If someone has already experienced a stroke and they have either mild deficits or they've recovered from deficits from a previous stroke, sometimes some of those deficits, which they may have experienced with their stroke may come out, or they may be unmasked, or they may become worse. And then also, if you have a tumor in the brain, that can, depending on where this tumor is, that can also result in stroke-like symptoms like weakness or numbness. Subarachnoid hemorrhage, which is a type of the hemorrhagic stroke, which results from an aneurysm or a blood vessel rupturing, that can also cause symptoms such as weakness or numbness on one side. And then there are a few other things. Peripheral vestibulopathies, you may have heard of the condition called benign positional vertigo. Vertigo is when someone experiences a spinning sensation. A majority of the cases of vertigo usually are related to inner ear problems or other problems, and they don't necessarily may not occur as a result of something occurring in the brain or from a stroke, but sometimes that can make it, because of the severity of the symptoms, the severity of the vertigo, it may appear that maybe this is a stroke, but that can certainly mimic a stroke as well. Alcohol, drug intoxication, metabolic encephalopathy, conversion reaction. So these are some other conditions. So metabolic encephalopathy is underlying kidney, liver problems sometimes can also result in stroke-like symptoms. And also drug intoxication, alcohol intoxication can cause confusion, slurred speech, and it may mimic a stroke as well. And then conversion reactions, the last one is more, sometimes some psychiatric illnesses can also bring on stroke-like symptoms as well. Stroke chameleons. Now these are atypical stroke presentations which appear to mimic another disease but are in fact strokes. So for example, strokes which affect a very particular part of the brain called the limbex cortex or the orbital frontal region, that can actually cause confusion, and that may be mistaken for a stroke symptom. Patients who have fluent aphasia, so problems with their language, or they're neglecting, the environment or one side of their body, and they don't have any motor deficits like no weakness, they may be interpreted as having confusion, which then can be thought of as a stroke, but in fact it's not. And then when you have strokes affecting certain areas of the brain called the thalamus, the corona radiata, the lateral medulla, they can actually result in chest pain or discomfort, which might mimic a heart attack, when in fact it may be a stroke that is causing those symptoms. And then finally, cortical infarctions that involve the motor cortex, basically they can cause weakness in nerve distributions. For example, are you familiar with radial neuropathy? Sometimes radial neuropathies will cause like a wrist drop. That actually a wrist drop can also occur when it affects a very critical area of the brain as well. So a radial neuropathy is something that affects a nerve in our upper extremity, but a stroke can also mimic those symptoms as well. Now, a special type of stroke, a stroke that affects the cerebellum, which is the balance centers of the brain, actually can cause GI illness types of symptoms. So it can cause nausea, vomiting, so sometimes even abdominal pain. So that can be suggestive of a GI problem when in fact it could be a stroke that's causing those symptoms. So you have to be aware both of stroke mimics and also other conditions which can also cause stroke-like symptoms as well. So I thought I'd just show you a few pictures. Now this is a CT scan of a patient's brain, and this patient has experienced a stroke on the right side of their brain, and there's actually a lot of swelling that has occurred. So all that area that you see that's dark, this area over here, that's the stroke. And then here's another, there's actually an MRI image as well as a CT image. So this first one basically shows that stroke, and this is the MR sequence, the MR image. And the second one is a CT scan, which actually shows a bleed that has occurred in that same area where that clot caused the stroke to begin with. So after a clotting type of stroke, sometimes patients can bleed in that affected area. And that's what you see there. So this is another patient's MRI scan. Basically, they've experienced strokes on an area called the occipital lobes. It's actually at the back of the brain over here. It's on both sides, so this is the right and this is the left. And you can't see it as well, but it's a little bit darker in that same region over here on this next picture of the MRI. And this is another stroke affecting the left side of the brain in the frontal region. This is more on the top, more superficial part of the brain. Another MRI affecting the right occipital lobe, so at the back of the brain over here. And this patient, unfortunately, has experienced strokes in several areas here. And this MRI over here. And this MRI basically shows a stroke in a part of the brain called the brainstem. It's a very small stroke, but it's a very critical area of the brain, so it causes very severe deficits. And you can see that same stroke over here as well. And this is at the back of the brain called the cerebellum. So this is where the balance centers are. And this is the stroke here on both sides. And this is actually a bleeding type of stroke. So this has caused a hemorrhage. So these are CT scans. And this is the bleed over here. And it expanded later on and it caused pretty significant deficits. So next what I wanted to do was to review the different types of strokes by frequency, and this is the whole focus of this talk will be on ischemic strokes because those strokes happen to be the most common type. So 80% of strokes happen to be the ischemic type of strokes, which are usually from a clot, which may have formed in a blood vessel in the brain or may have traveled from somewhere else. So of those strokes, 80% of those strokes, 61.5 actually result from a clot developing in the blood vessel in the brain. And that usually develops because there's damage to that blood vessel from risk factors like high blood pressure, and then cholesterol can start sticking to that blood vessel. And over time, it can start becoming narrowed. And at some point, when a patient experiences a stroke in that blood vessel, basically that blood vessel becomes completely occluded. And then sometimes the stroke can occur from a clot that's traveled from somewhere else. So 23.5% of those strokes are caused by a clot that has traveled from somewhere else in the body. So it could be from the heart itself, or it could also be sometimes even in the leg or one of the extremities, and that can go through the heart and go up into the brain as well. And then from the bleeding types of strokes, the hemorrhagic strokes, 5% of those are from subarachnoid hemorrhage, when you have an aneurysm that ruptures in the brain. And then the other 8.6% are caused by blood. Sometimes blood pressure can cause a blood vessel to rupture in the brain. So it's not from an aneurysm, but just the blood pressure itself, it becomes too elevated, it can cause a blood vessel to rupture. And usually it affects some of the smaller blood vessels in the brain. So risk factors for ischemic stroke, the strokes that result from a clot, high blood pressure actually happens to be the principal risk factor. So that's the number one cause for, of course, ischemic stroke, but it also happens to be the number one cause for hemorrhagic stroke as well. And that not only can cause strokes, but it also predisposes patients to heart problems as well. It causes blood pressure over time. If it's not well controlled, it can cause the heart to basically enlarge, and that can predispose patients to developing some other rare conditions like atrial fibrillation, which is a rhythm problem associated with the heart. And in those cases, those patients may need more potent blood thinning medications to decrease their risk of stroke. And then high cholesterol, it has a direct relationship with heart attacks, but high cholesterol is also a risk factor for stroke as well. And then diabetes as well, that's another big risk factor, especially if the diabetes is not well controlled. There's a big correlation between diabetes and stroke risk. Smoking, it's a very powerful risk factor for heart attack, for sudden death, and also for stroke, both the ischemic and hemorrhagic types of strokes. And atrial fibrillation, which is the rhythm problem I was talking about, that also predisposes patients to developing strokes as well. Obstructive sleep apnea, actually there's recent studies that indicate that sleep apnea, if it's not treated, can also increase the risk of stroke, and it also has an impact on the health of the heart as well. And then some other risk factors include, sedentary lifestyle, having a weight which is outside the normal BMI, a diet which is very high in salt, sodium, fats. Now, let's talk next about the management and treatment of stroke. So if someone is experiencing a stroke, is suspected of experiencing a stroke, an ischemic stroke that results from a clot, what are the next steps? What should, if an individual is experiencing stroke-like symptoms, what is the right thing to do? 911, exactly. So this is not something that if you're experiencing any symptoms, and even if the deficits are not that severe, you should never drive yourself to the hospital. You always want to call 911. Never have anyone else drive you to the hospital. And there's actually a very good reason to make sure that you call 911. And the reason is that stroke is actually a medical emergency. There are actually treatments available depending on when your symptoms began. And those treatments are actually very time sensitive. So you need to make sure that you get to the hospital as soon as possible. And going by EMS ensures that you'll get there fast. And not only that, those patients are then given priority over all other patients, regardless of when the other patients arrived in the ER. So when when the EMS arrives there, the first thing that they have to do is to try to stabilize the patient. And they also, while they're doing that, they're thinking about what could possibly have caused those patient's symptoms. So they're also thinking about other mimics of stroke as well. So for example, they'll check blood sugars to make sure that the patient doesn't have low blood sugars, which could cause confusion. And then as they're doing that, they're also thinking about that if indeed this patient is having a stroke, then could this patient possibly be a candidate for treatment? And there are treatments available. I'm not sure how many of you are familiar with TPA, IV TPA. Few of you? So this is actually a medication that can actually dissolve a clot if you are experiencing the clotting type of stroke. So there are different treatments available, but basically thrombolytic therapy or IV TPA, which is that clot busting medication that I was just alluding to, that basically is the mainstay of treatment for ischemic stroke. Now the thing with that is that it is a very time-sensitive treatment. So patients at best, they can receive that medication up to 4.5 hours. Usually it's 3 hours after the stroke onset of the symptoms, but if some patients actually can qualify for up to 4.5 hours, but the sooner you get that medication, the more likely that you are to get any improvement in your symptoms or respond to that medication. So it's very important to get to the hospital right away. And then there are also catheter-based treatments available as well, where they can actually go in and try to take out that clot from that blood vessel in the brain using a catheter. Now, I just wanted to talk to you briefly. There was actually trials. The first trial, it was the NINS trial. I don't know if any of you are familiar with this, but this is actually the trial that led to this IV medication called TPA, alteplase, which is the one that was first approved for patients who have ischemic strokes, and it can be used up to 3 hours. According to that trial, what they found is that patients benefited from this medication up to 3 hours from the symptom onset. And then what they found was that the faster patients received this medication, the more likely they were to benefit from that medication. And then later on, a few years later, another trial called the ECAS-3 trial basically showed that a select number of patients can actually benefit from this medication up to 4.5 hours after the symptom onset. And again, what they did notice is that those who received the medication sooner than later did see a greater benefit than those who received it later. Now, the problem is that this is a great medication, but there's a long list of contraindications or reasons why some patients may not receive this medication. So if a patient, the first thing when a patient arrives by ambulance, a majority of the patients, if they are medically stable, will end up getting a CT scan of the brain. And the reason this is done is to determine what is going on. Sometimes it could be a tumor, sometimes it could be a bleed, and it could also be an ischemic stroke. So that basically helps us determine what may be potentially causing the patient's stroke symptoms. Now, if it is an ischemic stroke, that will not necessarily show up on a CT scan. But if they've experienced a bleed or a hemorrhagic stroke, that will show up on a CT scan. So if that CT scan shows a hemorrhage, then unfortunately they are not a candidate for that medication. And also if there's also a suspicion that they may have experienced a subarachnoid hemorrhage, which results, also causes a bleed, but results from an aneurysm rupturing in the brain, then those patients are also not candidates for TPA. And if patients have had surgery in the brain or in the spine in the last 3 months, they're also not candidates because they can bleed in those areas. And then if they've had a stroke in the last 3 months, sometimes, depending on the size of the stroke, sometimes they may not be candidates, but that's not always the case. So that one is not an absolute reason not to get TPA, but sometimes patients, depending on the size, location of the stroke, they may not, depending on where it occurred. And then if they've had any serious head trauma recently, that could also be a reason why they may not receive it. Blood pressure, if it's not controlled. So if the blood pressure is running high, the ED physicians make every attempt to try to control that and bring that within safe parameters. But if they're not able to, then that could be a reason why they can't get that medication as well, because getting that medication, if your blood pressure is not well controlled, can increase the risk of a hemorrhage happening in the brain. And then also if they've had a seizure, sometimes that can cause stroke-like symptoms as well. But that's not always a reason not to get that medication, because a seizure can also occur at the onset of a stroke as well. Sometimes that can be the first presenting symptom. And then if they have any other bleeding happening anywhere, sometimes if that bleeding cannot be well, controlled, and it could be life-threatening if it were to become bigger, or if the bleeding were to worsen, then that could also be a reason not to get that medication. And finally, some patients who receive medications like for atrial fibrillation, if they're taking Coumadin and their blood is too thin, then that also may be a reason why they can't receive that medication. And with the newer medications, like there are some newer medications like Perdaxa, you may have heard of some of these, Eliquis that patients take for atrial fibrillation. If any patient is taking any of those, then they will not be candidates for this medication either. And then, because of this very strict time window and the fact that a lot of, a good third of the patients, especially if they receive the medication too late, more towards the end of the window for opportunity, those patients may not do too well. And there's a very low risk, actually not low risk, but very low chance of patients getting better if that blood clot is actually affecting one of the larger blood vessels in the brain. If we actually can see that blood clot in one of those blood vessels, then they can actually go in and try to take that clot out with a catheter. So that's the second part of the treatment, endovascular treatments. Now, that is not something that we currently have available here at Kadlec, but we usually send those patients out to Sacred Heart Hospital in Spokane, or sometimes up in Seattle as well. And those patients, if they do have a clot in one of the larger blood vessels, then they may be candidates for these treatments, and therefore they may be transferred out of Kadlec. Now, I'm not going to talk too much about this, but basically this is just kind of goes into some of the science as to why these catheter-based treatments work. So basically, when a clot goes in and obstructs flow to brain cells in the brain, there's some brain cells that die immediately, unfortunately, or within minutes. Now, there may be some brain cells that may be getting reduced blood flow, but may not die immediately. Now, those brain cells are the ones that can be salvaged using these catheter-based treatments. So currently, the window of intervention is 6 to 8 hours if it affects one of the blood vessels in the front part of the brain, and up to 24 hours if it affects a blood vessel at the back of the brain. But there actually will be some changes. We've had some exciting trials with some exciting results recently that indicated that actually some patients, select patients, can benefit from these catheter-based treatments up to even 24 hours after the symptom onset. So that helps. If a patient wakes up with stroke-like symptoms, they unfortunately most of the time are usually not candidates, because they fall outside that 4.5-hour window for intervention, unless they happen to just go to sleep and then they woke up and they knew exactly when they went to sleep and they are within that time window. But if they woke up and they last were seen normal, let's say, the night before, then unfortunately they may not be candidates. But now with this exciting new trials that have demonstrated some benefit for up to 24 hours, I think a lot will change and more patients will get to these catheter-based interventions. And these are just some of the devices that they're using. They used to use some of these older devices like the Mercy device. This was the first one that was approved by the FDA to retrieve those clots. But over time, they've actually the devices have gotten better and they're more efficient and being able to take out that clot. So some of the recent trials have used these newer devices like the Solitaire and the Trevo device, and patients seem to do better with these devices. So the trial that I was alluding to, the Dawn trial, that was the first one that came out. And that one was conducted in many centers in US, Canada, Europe, and Australia. And that trial ran from 2014 to February of 2017. They enrolled about 206 patients. And what they ended up doing is they ended up stopping that trial early at 31 months. And what they found is that a select number of patients actually did really well with these catheter-based treatments. And there was a clear benefit. So as a result, they had another ongoing trial. This one is called the Defuse 3 trial, and these results actually were just reported at the International Stroke Conference just recently. And basically, this trial replicated the results of the previous Dawn trial. So over time, there's going to be there'll definitely be more opportunities to help patients who have the ischemic types of stroke. So definitely, even if you wake up with the symptoms, you definitely want to call 911 because you may be a candidate for these types of, for the catheter-based treatment. Okay? And I think I just want to talk briefly about stroke prevention, but Abigail Richardson, she will also be talking and focusing on this as well. But I just wanted to kind of go over some of the risk factors that I talked about earlier. So when it comes to stroke prevention, once a patient has experienced a stroke, they are at a very high risk of having another stroke. So it becomes very important to control those risk factors that may have been identified during the hospitalization, treating those, and the more those are treated, the lower the risk. So if they have patients have been found to have high blood pressure, high cholesterol, diabetes, sleep apnea, atrial fibrillation, making sure that those conditions are controlled then decreases the risk of another stroke happening. Now, sometimes patients may end up undergoing an extensive workup, and they may have disease in the carotid arteries in the neck. If they have significant narrowing, sometimes they may need surgery to clear some of that blockage, and sometimes they may also put in stents to help with that as well. And then if patients are smoking, then trying their best to quit smoking also decreases the risk of stroke. And then diet plays a big role. You may have all heard about the Mediterranean diet. The focus is more of a plant-based diet that's rich in fruits and vegetables. That tends to be more protective when it comes to stroke prevention. And then also exercising. And then if you have atrial fibrillation, then the treatment is different than with other types of strokes. Patients who have been found to have atrial fibrillation, medications like aspirin and Plavix, some of you may be familiar with that, those medications may not be helpful in patients who have atrial fibrillation, so they may need more potent blood thinning medications to help decrease their risk of stroke. And then we talked about carotid disease, so surgery sometimes. And hemorrhagic stroke, I think that will probably be a focus on another presentation. That's the 20% of patients experience hemorrhagic stroke, which is the type of stroke that results from a rupture of the blood vessel. But I don't think we would have time to cover that today. So I think I'll probably end the presentation at this point, and then I'll be open for questions if any of you have any questions.